Today we're going to talk about stromal lesions of the breast. And we'll pop up with the disclaimer here that you guys can read at your leisure, pause on screen, let me know in the questions if you have any questions about the disclaimer. Okay, so I think this kind of lays out what we're going to be looking at today. So fibroadenomas and phloides tumor, because those are always in the differential with each other. Our fibroblastic and inflammatory lesions, got a couple of those, and we finish up with a couple vascular, neuroendocrine, neurodifferentiation type things, and then the challenge cases, which are a mix of everything. Okay, so fibroadenomas and phloides tumor. First case.
All right, towards the breast tissue from low power. It's very fibrous. So we're gonna go in and just look around first. This part looks a little funny, so we'll revisit this. A little funny too, like the previous one. This one's not too bad over here. Not too bad. A little bit maybe, but not as the best example. Maybe better here. Alright, let's go back to the first one. So, over here, it looks like this very fibrous stromal component with these kind of like, sort of like, you know, I think it doesn't project very well, but it looks kind of benign glands. The cells look pretty decently uniform and small and not ugly, but they're kind of squished. They're very slit-like.
Definitely.
And how old would this patient be?
Let's say this patient is 24.
Okay, so young person. So this is first and foremost a benign lesion.
I would agree with that. Yeah.
And it's a fibroadenoma.
Okay. So now my question for you is why fibroadenoma and not fibroadenomatous change? What's one thing in the history that would tell us one way or the other?
What would be?
Think imaging.
Fibroadenoma is like usual. Well, it's a discrete mass that's mobile, and I think it changes with like hormonal status.
Right. Right. So we'd have a definite, like, palpable lesion, probably in a 23-year-old. It would fluctuate with the cycles. These tend to also flare, like if women are pregnant, and like a definite mass. Whereas fibroadenomas change. It's like it's not necessarily a mass lesion, but we're seeing the same type of things. Good. Okay. We get to go straight into another case. This one maybe a little easier, harder?
I mean, it's similar to what we had before. You had sort of these very squished serpentine sort of glands, I guess, in sort of this very thick stromal sort of background. Going on closer view. These ducts look a little more thick, but I think it's not projecting too well, but I'm assuming they're normal.
Yeah.
Yeah.
I think you're still okay.
Yeah, I think we're still in the okay region. It's just, it's projector. So, this one looks like it's more of it's a bigger specimen. This looks like maybe an excision specimen rather than a biopsy. So, there's probably a mass. So this one will probably be leaning more towards a fibroadenoma, you could say, for more definitive, if they don't provide you with clinical history, which they should, as good as clinicians.
And then
See this region.
yeah. Are you worried about any of that?
Kind of looks like. Well, if you focus in on some of them, you might be concerned for can this be a Phyllolese tumor, but not quite. The stroma doesn't have that look to it.
Okay.
Yeah.
At first I thought you were worried that maybe it was a papillary lesion.
I think it'll be stretching a little
Okay.
just because, yeah, like
Good.
that's a very fat papillary lesion. That's a papillary lesion.
Right. Well, and I think what's important with all those little pieces is that they really just look like they've kind of just fallen off of everything. There might be like some papillary features in there, and even if it is a papilloma, if it's all within the lesion, then they still got what they were looking for, and it probably was this well circumscribed mass that they were trying to excise, and they got. Okay. And you said not Floides tumor, which is good. So we have architectural patterns associated with fibroadenomas. And even though clinically they don't mean anything, do you know what the predominant pattern is in this lesion?
Let me see. What are some patterns?
So there's two main patterns, and like I said, they don't matter clinically. It's just kind of where are you seeing the proliferations. So there's pericanalicular, where it's the stroma is more condensed around the glands. So instead of seeing these slit-like spaces like we have in this lesion, you'd have a lot of like really small separated glands in between this expansile stroma. What this pattern is displaying most of is the intracanalicular pattern. So that's when you get so much expansion between the ducts that it compresses the glands, and you get these squished slit-like spaces. And when you see a very exuberant amount of that in a fibroadenoma, that can actually mimic a Floides tumor. But the overall pattern still isn't right. Like we're still not seeing like the leaf-like projections and those kind of things that we would expect in Floides, right? Okay, very good. So very common lesion, right? This is probably the most common thing that we see. Mostly younger women, but if you have someone who's postmenopausal is taking hormones, or someone that's obese, right, they're going to have higher estrogen levels. You can see these in men. So again, are they taking exogenous hormones for whatever reason? Do they have gynecomastia? And for some unknown reason, they're more common in African American women. There's a whole page, well, I guess half a page in your handout goes over the Carney complex. So where the fibroadenomas come in is that Carney complex is associated with breast myxomas, but sometimes they're described more as like a myxoid fibroadenoma. So it's just something to keep in mind. And yes, like you mentioned, they're mobile, they're well circumscribed. They can calcify over time, so once in a while it's a calcified lesion that they're biopsying or excising, and you'll have a fibroadenoma. So calcs aren't always scary. Okay, well circumscribed again on gross. They can be gritty if you have calcs in them, and they always have these pushing borders. So when you're looking at benign lesions, they tend to have pushing borders, whereas our malignant lesions tend to have more infiltrative borders. There's a lot in here talking about the biphasic growth pattern, but pretty much your glands should be benign. You can see things like UDH, which we might have had a little bit of in our examples. Keep in mind those lactational changes, right, associated with pregnancy, and rarely you'll see atypia associated with a fibroadenoma. sometimes it can be really tricky, especially in a biopsy, and it'll be like right beside the fibroadenoma, or you can have cancer that's right beside the fibroadenoma. So again, on excision, they'll kind of sort those things out. So where it says like must list unusual characteristics, so those are things that are making you go, is this a cellular fibroadenoma or is it a low-grade phylloides? Really, a high-grade phylloides you're not going to confuse with fibroadenoma, because fibroadenoma doesn't have the features of phylloides, which clearly we're going to go through later, since the title of this section is Fibroadenomas and Phylloides Tumor. So in the examples, you have some nice intercanalicular pattern above, and the bottom's just showing more of the myxoid stroma that you can sometimes see. So it's more of like this pale blue-gray or steel blue. In that picture, it's maybe a little more pink. So always keep in mind what your H&E is wherever you are and with consults. Your positive stains, so your hormones will be scattered positive within your epithelium, because your epithelium's normal, right? It shouldn't be diffuse. But also some of the stromal cells will be scattered positive, and that really makes sense when we consider that these lesions tend to be hormone receptor positive, and somebody has a very loud radio or something in the hallway. Okay, molecular, so you don't need to run molecular on these, but interestingly is the lesions can be either monoclonal or polyclonal, but your epithelial component, which is benign, is going to be polyclonal. And over half of them have these MED12 mutations in the stroma, which is found on chromosome X, long arm 1-3, and that leads to estrogen and extracellular matrix organization problems. And these are also seen in uterine myomas, so very similar profile, but again, you don't need to run molecular on either of those tumors to get the diagnosis. The differential is all things that kind of look like fibroadenomas, and they can either watch these and see if they're growing or if it's bothering the patient, or they're just causing a lot of diagnostic problems, like maybe the calcs are just, they look really bizarre, and every year they keep saying like, what's up with these calcs? They might just take it out to be done with it. And also if they grow very, very, very rapidly. Obviously they're benign, but because they are a proliferation, right, they are a tumor, so we still have the 5 to 7% lifetime risk to both breasts if a patient has a fibroadenoma. Okay, and then that's just a snapshot to show you the difference between the intracanalicular, which is probably the one that I see most often, and the pericanalicular. You don't have to report the pattern because again, clinically it doesn't change what they're going to do. Okay, next lesion.
So it's a very sort of fibrous lesion with a lot of glands, I would say, ducts, kind of like scattered throughout. Going on high power, just looking around a little. Going on higher power, so looking at these individual glands. I don't know, the first thing that strikes me is that it seems to be that like the stroma surrounding these glands are a little more blue, they're more cellular compared.
Yes, that is actually a very important thing to notice.
And the epithelium themselves looks relatively benign in this area, at least. They're very, very homogeneous, lack of a better term.
But not too homogeneous.
No, not too homogeneous. Like not the weird kind of things you expect, let's just say.
Okay.
Yeah, definitely the most striking feature is that the stroma is a little more like cellular, I would say, compared to the previous ones we saw.
Excellent. Does the overall architecture look a little different or the same?
It's a little more crowded, like it seems like. It is still well circumscribed like the previous case, relatively. Over here. This is just tangential. It's skin.
It's skin,
It's
yeah.
skin. Yeah, it's skin.
Yeah,
Never
they
mind
give
that.
you a bonus.
Okay. It does seem to have like the glands are a little more bigger, sort of. They're kind of like forming more undulation, curvature, I guess.
Curvature.
Curvature.
Maybe even leafy. Can I
certain,
say leafy?
certain types of leaves, maybe.
Certain like maybe like I don't know, like
I was
palm
think-
fronds or
I always think lily pads for some
lily
reason.
pads. Okay, that's good. It's like I have like I always say I have a brown thumb. You know, I can keep
Mhm.
something alive, but I don't really have a green thumb. So, okay, lily pads. I like that.
So, saying that, so are we in Phyllodes territory here?
We are definitely in Phyllodes territory. So what do we get to do now?
What do we get to do now? Treatment wise or?
So,
Testing
what do you
wise.
know about phylloides? Like when we
It's-
diagnose phylloides?
Well, I know there's a malignant version of it,
Mhm.
so it's probably a good idea to look if there's any malignancy, like malignant version of it here.
Sure. So what kind of features do you think we should look for? I know these are rare tumors, so
Mhm.
you might not have seen one yet.
Well, if you look at malignancy, usually it's like just basically just cells that are just, I guess, more pleomorphic and
Yeah,
ugly
definitely.
looking.
Ugly
Um,
looking.
I guess mitotic figures.
Mitotic figures, and you actually got the final feature already when you talked about how well circumscribed the lesion is.
Mhm. Oh yeah, infiltrated the borders.
Right,
Like that.
right. So you got all that. So I'm not going to make you hunt for mitotic figures in this
Can we
one.
assume that there's none?
There's some, but
There's-
they're relatively normal looking in this. I did have an annotated version of this slide, but unfortunately that glitch where the slides are going out of order is still happening, so I had to delete my beautiful annotated slides where I actually highlighted the mitotic figures for you. But this one to me is more in the benign range for the things that we kind of talked about. Like everything's relatively bland.
Yeah.
It looks well circumscribed from what we can see here, and there's not a lot of mitotic figures, and none of them really look bizarre.
One day we'll have AI to help us find the mitotic figures.
Yes, that is actually a very good use for AI. Same with like counting lymphocytes and stuff like that. But okay, I digress. Okay, so we like benign phylloides for this one. Here's another one.
Okay, so it's a little hard to tell because
Mhm.
it's core biopsies.
Yes.
But looking at what we have here, the stroma is very cellular, like the previous case. The epithelial cells, they look, not like crazy pleomorphic, at least in this field. Not seeing any real mitotic figures, so it's probably on the more benign case. But we can't really sort of evaluate for infiltrating borders. So
Right.
we might have to put like a caveat for that in the note.
Okay. And then is phylloides an epithelial lesion or a stromal lesion?
I would say it's stromal lesion.
Right. So, like you can have atypia in these lesions in the epithelium, but really we're focusing on the stroma. Okay, so you're gonna look for mitotic figures and atypia in the stroma.
Oh, okay.
I know you're gonna find some of them because they are crazy.
Yeah. These ones don't look that good. Might be hard to find mitotic figures, but that's
There's a
fun to
lot of
look.
them, but they are crazy. Like they kind of look like star anise. Like they're just every which way you can imagine. They're quite large and eosinophilic in this case. And again, I do apologize because I did have them annotated to make them easier to find.
It's okay. We could just keep on talking all the time
Yeah.
for this.
But one of the things that you saw pretty much right when you came into your higher power field is the multinucleated giant cells that you can sometimes see with these tumors, and they can be very pleomorphic. So you're not supposed to count those in your pleomorphism when you're looking at that. Okay, so when we're looking at benign versus borderline, like there you go. That don't look right. So borderline is just kind of like always like you're in that realm where you're like, I can't say it's benign and I can't say it's malignant because it doesn't quite hit the features. But when you have like this kind of pleomorphism, and I promise you there's more than 10 mitotic figures in here, and most of them are that kind of bizarre mitoses. This is definitely a malignant, or consistent with malignant phloides. Now, can you hedge on these? Yeah, you can hedge. Like you could say, oh, I have mitotic figures up to this. There's pleomorphism, there's multinucleated giant cells. The constellation of features is consistent with phloides tumor, but definitive classification will be rendered on excision or something like that. Everyone kind of has their own flavor of how to fill that out. But pretty much the important thing is just conveying to the clinician that this needs to come out.
So on this one, compared to the other case we had, could it be just the biopsy causing distortion? But it looks like the architecture looks a little more ragged and more like,
Yeah, so
like compared to the other one that was more sort of neat and clean. I think some of the part could be just the biopsy, but just some of the space is just a little more.
no, that's definitely true. And so like even if we were considering, like let's say on the other end of the spectrum, right, is back to that cellular fibroadenoma, you would not see any of that pleomorphism and stuff. So, and you have to imagine they're using these tiny little hollow needles to pull out these biopsies, so you can get distortion with that. And then after they get the biopsy, we're taking forceps and manipulating these cores, so you can get some distortion that way. And this is pretty skimpy, but it's enough to make you suspicious and make you go like they need to do something with this. This needs to come out. So this is a malignant phloides, or what I would call malignant phloides. Okay, so the slides are a mashup of your handout. On the handout, I split out benign and borderline versus malignant because I think it's more helpful to see those things separated out, but it didn't really make sense to necessarily repeat all that information twice over in slides, especially when for the most part they look the same. It's the pleomorphism, mitotic figures, and infiltrative border that's going to raise your suspicion for borderline versus malignant. So whereas our fibroadenomas are more common in African American women, our phloides are actually more common in Asian women. And when we consider that phloides are actually less than 1% of all tumors, but they represent 7% of tumors of breast tumors in Asian women, that's actually a huge jump. And because these are rapidly growing lesions, there's something that you want to take care of relatively quick. Yeah, there we have from 1 to 40 centimeters, average of 4 to 8 at time of excision. So you notice the clefts, which is really nice. Sometimes you can actually see those grossly. And for anything that they're suspicious of phylloides, obviously from the biopsy, you want to make sure that you're sampling those extensively. Not only for, like, they might have more focal high-grade features, but also the infiltrative borders could also be focal as well. And we want to make sure that they have good clean margins with this, because otherwise they will go back if it's a lumpectomy. And even if they've done a mastectomy on these patients, they have a relatively high rate of recurrence. Okay, similar to the fibroadenomas, so you need to have your stromal cells and you have to have your benign epithelium. The cambium layer, which was where you said it was very blue around the glands, so that's taken from the trees, and I do have a picture of the cambium layer, just to kind of highlight that for anyone who missed that. The stromal overgrowth is when you're at high power and you're going through phylloides, and it's just, you have an entire screen that's just stroma. There's no glands anywhere to be found, or the sea of stroma. And that's something that in the short review video that I did on a malignant phylloides case, I do highlight an area of stromal overgrowth in that. Nuclear pleomorphism, so again, if it's benign, you shouldn't really have much, because if you're considering is this a low-grade phylloides or benign phylloides versus cellular fibroadenoma, fibroadenoma is not going to have bizarre pleomorphism. Only count the mitotic rate in the stroma, so that's an important thing to remember, because you can have a lot of mitotic figures in your epithelium, but you don't want to count those. And sometimes these can have fat in them if they're really infiltrative, and at that point then you also want to consider, is this possibly a liposarcoma? Phylloides tumors are notorious for having heterologous elements, and what that means is something that doesn't belong in the breast. They're going to have that there, and when you're looking at malignant phylloides, that's when you're looking at your sarcomas. So rhabdomyosarc, osteosarc, or liposarc, all those kind of things that you can see elsewhere, you can have mixed up with phylloides. And it's actually far more common to have those items as part of a phylloides tumor than it is for those to be breast primaries. A lot of information there. Okay, and then we can see all our regular epithelial things. So whether you're looking at UDH, is there ADH, DCIS, LCIS, or even invasive carcinoma, you can see all those things. It's just very uncommon. Phylloides tumor, you should also be able to see your myoepithelium, because again, your epithelial component is intact and it's benign. Okay. So a little bit of difference between your benign phylloides and malignant phylloides for stains. I always love looking at stains that are unusual for where you are, and c-KIT is the one that stands out. So if you're in the breast and you're thinking, hey, is this fibroadenoma versus phylloides? If you slap a CD117 on that, whether it's benign, borderline, malignant, it should be positive for c-KIT, whereas a fibroadenoma should be negative. Your Ki-67 is only helpful if you're considering borderline versus malignant phylloides, because fibroadenomas and benign phylloides will be in the 1 to 5% range. So that's not really helpful. And then when you go into the malignant realm, you also pick up some extra stains. And by that we mean you're more likely to see P53, you can have focal P63 positivity, so not just in your myoepithelium, but also within the tumor. You can see keratins in your phylloides and P40 as well. Whereas all those stains should be negative within the stromal element of benign phylloides. Okay, and molecular, pretty much anything goes. We have that addition of the 1Q, and then a whole bunch of others that are somewhat, not necessarily related to other tumors that we see in the breast. You can have increased PAX3 and 6-1 expression. And pretty much how phylloides works is the more mutations you have, the more likely it is to be higher grade. If it's a recurrent tumor, if they've excised it and it's come back, it's more likely to have more mutations, more likely to be higher grade. So always consider that. We've gone over treatment, so they tend to excise them. They may do radiation, which can decrease recurrence. There's no data to suggest that chemotherapy is helpful, but that's also because these are really rare tumors. So when you have rare tumors, it's very difficult to set up a trial to actually see the efficacy of chemotherapy or targeted agents. The good news with phylloides, though, is that even though they can recur, greater than 90% of all phylloides tumors, so whether it's benign, borderline malignant, most of them have a benign course. However, they can metastasize to your bone and lung, and when that happens, that is often going to result in the patient dying. And something to note is that last week when we talked about micropapillary carcinoma, when that metastasizes, it looks exactly the same as it would in the breast. With phylloides, only the stromal component is going to metastasize. So you're not going to see any glandular epithelium, and nothing really to necessarily help you know this is breast, but the history is what's going to help you there. And again, that c-Kit should be positive, and you can run your gamut of other stains as well. That's it for phylloides. I did set up this, and this was a really nice picture just to kind of show, again, you can have that intracanalicular or pericanalicular pattern. So when we think phylloides and classic phylloides pattern, that's an intracanalicular pattern where you have the leafy fronds. So just keep that in mind if you're looking at something and you're like, I don't know, is this maybe phylloides, but it has a different architecture, it's not leaf-like. It could still be a phylloides, and just like fibroadenomas, you often have a mix of the two patterns. Okay? It's a lot on phylloides, I know. Okay, fibroblastic and inflammatory lesions.
Alright, more cores, very cellular, low power. Let's just pick a random area and zoom in. Alright, again, very cellular. The cell seems to be spindly, relatively uniform in shape. A few bigger ones. Just looking around, it's pretty much the same lesion throughout.
Yeah.
I think it's just falling apart here. I don't think that's the white stuff or anything. Here, at least. Looking around. And over here, it does kind of look like there's something there. I don't think it's just all artifact. But I'm gonna keep looking around and see if there's anything better.
Is there anything else that kind of is associated with all those cells?
Decent amount of blood vessels.
Yeah. Or, does it maybe make you think of lesions elsewhere if you didn't know that this was breast?
Like an angiofibroma or something.
Okay. So what about all this stuff? All this salmon pink stuff that's just kind of everywhere.
Yeah, okay. Is that collagen?
That is collagen.
Okay. So, it's fibroblastoma?
Okay.
Some sort?
You are so close.
Mm.
You're like 99.4% of the way there.
Okay.
You're missing one tiny little component.
Mm.
And it might be a little bit of guess what I'm thinking / just know what this is. But you said, okay, we'll go on like a roundabout way of helping you get there. So you said that there's a lot of vessels.
Mm-hmm.
Okay.
What's in the vessels?
Yeah. What's around the vessels and in the vessels?
Musculature.
Yes. Okay. Guess what I'm thinking is working today. So, what's a word that we use for muscle?
It's myo.
Yes.
So, myofibroblastoma.
Perfect. I love it. We should stop right there and just walk out and be happy, right? Yeah, so this is a myofibroblastoma. And one of the things that they often are, you need to differentiate them from is a spindle cell lipoma. So that thick, ropey collagen can throw you for a loop. Sometimes these can have a lot of adipose in them. So again, that would make you think, oh my gosh, is this a spindle cell lipoma again, right? Because you can either have very fibrous elements or where they're lipid poor, or you can have spindle cell lipomas that are lipid rich and fibro poor. So
So I'm just looking around, and we can move on to the next slide if you would like.
well, oh, and this one is kind of more of a haphazard arrangement. So sometimes they're more nested. So I think that might have made this a little harder, but this one just had such beautiful ropey collagen that I was like, no, this is the one I want you to look at and kind of get in your mind.
So the myo component is really just around the vessels.
Sure. That's kind of like the only place that kind of looks like muscle, because most of it is collagen.
Okay. Or is it just the slide?
And the cells themselves, but they look so epithelioid here. Sometimes they're more spindled, and that might help more.
But is the myo, like the muscle component, ever prominent, or is it just the slide? It's just not showing it too well.
So the myo part is where you're looking at like your actual cells.
Okay.
Okay, but it's just they look very epithelioid. So I think if I would have said just look at the cells, that wouldn't have really helped you.
Okay.
Because to me, I'm like they're very plump. They don't like I'm not thinking muscle cells when I'm looking at them necessarily. So yes, my vessel thing was just a really roundabout way to get you to say
okay.
myo.
I see.
Okay.
All right.
All right. So again, another uncommon rare breast lesion. This is like a recurring theme, right? Except for fibroadenomas, everybody has those. So less than 1% of all tumors. And remember when we did our bone soft tissue stuff, we were like, remember things where guys get it more than girls. So this is actually the only breast lesion where males actually have a slight lead on females. And these are palpable painless masses. They tend to be slow growing. So again, you know, when we do find them, like they will want to take them out. You can have mammary, which obviously is what we're looking at here with a breast primary. excuse me, but you can also have extramammary origin. So those are things that are going to be like in the groin, involving the vagina, paratesticular, and they always kind of have the same appearance. So either they're going to be very well circumscribed, or they're going to have this smooth lobulated appearance, and they're going to be firm or rubbery. And they're almost always solitary, but once in a while you can have a patient who's lucky enough to have bilateral lesions or multicentric lesions. And with that nodular or whorled appearance, like they're going to look very similar to a fibroadenoma. If you were down in the vagina and stuff, you might think leiomyoma. And again, the morphological overlap with spindle cell lipoma. And the bottom right just shows you again that really nice thick ropey collagen, and the arrangement there is the cells are a little more spindled, they're more fascicular. So I think that's maybe a little more classic look. And even though this is well circumscribed, it's not going to have a true capsule, and it might really compress the normal breast tissue at the periphery of the lesion just because of how these tend to grow. So you might have some really distorted looking normal breast lobules at the periphery. So you can try not to let that scare you. You can see those floret-like giant cells that we've seen in other lesions, mostly bone soft tissue again. You're not really going to see mitoses. You can see mast cells with these, and often the mast cells will be interspersed with the spindled cells. And again, you can have those heterologous elements. So don't be worried if you see a little cartilage or there's some bone or, all sorts of different things that don't necessarily belong. Okay, all our hormone receptors should be positive. There's our muscle with smooth muscle actin desming. Your HCAL-desmin can be positive, but HCAL-desmin, if it's positive, so half your cases will be positive with less than 10% of cells. So even if it's positive, it's going to be very focal. BCL2 can be positive. So again, like unusual stains, your negative stains. So if you're thinking, yeah, this looks kind of looks like maybe like you're thinking, I don't know, is this solitary fibrous tumor? You could run a STAT6 on it. It's going to be negative. You could throw an S100 on that, and again, that's going to be negative. What it does have is an RB1 gene loss, and then it gets that second hit, or like Knudson's hypothesis, where you get a second hit on your RB and that gets lost, and that's actually a common finding with these. But again, you don't necessarily have to do molecular on these. Your IHC stains would be sufficient in most cases. Solitary fibrous tumor, again, just to remind you, it has that NAB2 STAT6 gene fusion, which is on chromosome 12, Q13. And the common theme to this area of tumors is it fibromatosis, is it PASH? Okay. As with most things, they're going to just cut this out, and they're benign. And even though I have written there that no recurrences have been reported to date, there's a couple of rare case reports where they're like 17, 20 years out where they reported these lesions, but it's actually unclear if it's a new primary or if it's actually a recurrence of the same lesion. And it's further muddied because they don't give the locations of the primary and the recurrence or suspected recurrence. So officially, no recurrences reported to date with these. And then in your pictures, I just have examples of like epithelioids, so you can really picture in your mind why that would look terrifying, and you would think, is this carcinoma? And then lipomatous, again, why we go back to thinking, is this a spindle cell lipoma? Because that collagen's still going to be there. Okay? All right.
In contrast to the previous ones, this one is not that cellular, really
Right.
superficially. A lot of stroma, very pink. Some glands, ducts here. So let's just zoom in and do a quick look around. First off, these ducts look normal. Yes, yes. Looking around, so stroma, and then some more ducts, and then look around on this piece here. It's kind of more of the same at low power. So let's just go back, maybe let's say to this one and see what we see here. But I think it might be in the other one better.
I think I agree with that.
Yeah. Yeah, let's go back to the other one. I think the other one illustrates.
Good. This makes me happy because I feel like you've zoned in on it already. Yes.
Yeah. So notice how there's a lot of clefting, lack of a better term, a lot of white sort of just channels sort of going through it. And they kind of look like it's lined by, maybe mistaken for endothelium. Although if you have this many blood vessels in this area, then I think you have a lot of problems. But yeah, these look like blood vessels, but they're not. They don't contain any red cells. At least not here. So fake blood vessels,
pseudo blood vessels.
Angiomatous, stromal, because it's in the stroma, and
We have a lot of them.
We have a lot. I guess it's just like, yeah, so hyperplasia.
Right.
So that spells P-A-S-H.
Pash. I'm having like a proud mama bear moment here because you described that so beautifully and perfect. Like that's exactly what PASH is. So it's a stromal lesion that mimics vessels. Like you could think, well, are these capillaries? Are they like lymph vessels? But they are lined by stromal cells, so fibroblasts are not lined by endothelium. And as was so beautifully pointed out, there are no red blood cells in them. Now, on occasion, they will trick you, and there will be a couple red blood cells in there. But if you're seeing a lot of blood somewhere, usually that means that it was really close to a biopsy site, and you could just have hemorrhage spilling over because of that. Okay, beautiful. Do I have anything to add to this? Because that was honestly just perfect. Okay, we see this all the time. So common incidental findings. So more than a quarter of all biopsies done are going to have PASH. Again, we have that wide range of 10 to 50-year-old women, so think childbearing age when you're thinking PASH, okay? It can also happen in postmenopausal women that are taking exogenous hormones, and they tend to increase their amount of PASH if they're predisposed to it at puberty and with pregnancy. So these can form mass lesions, and during one of our earlier lectures, I was trying to veer one of our residents away from using PASH as the mass forming lesion, but yes, it can form a mass forming lesion, so this is me eating a little crow, which is fine. I don't mind eating crow. It's not too bad, just put enough sauce on it. And pretty much it's going to look very similar to fibroadenoma grossly, but with fibroadenoma where you can see those cleft-like spaces, you're not going to see any of that with PASH because these are all very, very small spaces. Wide range of sizes with them as well, and seriously, I have nothing to add under the microscopic. You got all of it, except for focal should have one L, so that's great. I do spell check, and it did not pick that, but maybe it's used for something else. Okay, usually the stroma is paucicellular, which can also make it a little more confusing as to whether they're vascular channels or not, and the cellular variant or fascicular PASH. So pretty much with that, you're just going to see these really blunt poorly formed fascicles, so just a lot of cells, but you're still going to have those cleft-like spaces. Okay, so if you were concerned, like maybe this is a hemangioma, maybe it's angiosarc, I don't know. You could do your vascular stains and they're going to be negative. CD31, factor VIII, ERG, pick your marker. It's not going to be happy with you. They are going to be CD34 positive, like most breast lesions. Your smooth muscle actin, smooth muscle myosin heavy chain, and ERPR is also going to be positive. There's no molecular to know for these, so we can all say a hallelujah for that. No molecular to know. And treatment. So if it's a mass-forming lesion, they might take it out if they don't already know that's PASH. And you know, if you have a biopsy and you're saying, well, hey, all I got is PASH, they might be like, well, did we miss something? Is this concordant with our imaging? So always keep that in mind. And these are benign, and rarely they recur, because again, they're hormone positive, like they react to hormones, so in our younger patients, more likely to have recurrences. And there's a couple more nice pictures of PASH. So really, this is just one of my favorite lesions to look at. I just think it's so beautiful to look at. So spend a little time with that if you're not sure about it. Yeah. Okay, moving on. I'll stop gushing.
Alright, another very pink stromal case.
Yes.
For lack of better terms, it's from a lumpectomy. See some nice colors here.
Yeah.
Well, let's zoom in and see what we're dealing with here. Something you don't see every day. Alright. I think those are small ducts, glands.
Mhm.
Okay. Some adenosis going on?
Yeah, maybe.
I don't think
A
this
little
is
bit.
what you're, because I'm looking at the epithelium, stromal lesions.
It's stromal lesions today.
Stromal lesions.
You already found it. Well,
Is it just
an
that
area
one
of it.
area?
There's a couple areas of it, but you found probably one of the best ones.
Okay, let's go with that.
So your low power view of it is what?
It looks like a bunch of lymphocytes.
Okay. And your high power view of it is?
Well, there's a gland or two in here.
Okay.
Yeah. But it's like surrounded by this cup of lymphocytes.
Beautiful. Beautiful.
Mm-hmm. And the stroma looks kind of, does it look a bit like, I guess like cotton candy-ish, like glassy?
Yes.
Looks kind of different, that's all.
Yeah.
And just a lot of lymphocytes.
A lot of lymphocytes. Lot of lymphocytes. And this also was done because it was something that was also asked about a couple weeks ago.
Okay.
So what do you think we have here?
Well, if the lesion pointed out has lymphocytes and you seem to focus on it, I feel like lymphocyte is part of the name.
Yep.
So
Good.
lymphocytic something.
Yeah, unfortunately the other word is just like a generalized word that doesn't really tell you much, even if you try to, you know, use all our medical terminology and break it down, because, you know, we all love that class.
So lymphocytic, let's see now.
Okay.
It's like kind of like the, if anyone watched the Red Green show, it's like the Possum Lodge word, guess the word game. So,
yes, for anyone who doesn't know what Red Green is, we are both Canadian. So Red Green is a stand-up comedian in Canada and had a show, and it's pretty funny, so you should check it out.
It's on YouTube.
It
All
is
of it.
on YouTube, all of it. It's amazing. So all you need to know in life is that you need duct tape and WD-40, and you can fix anything. All right.
So, since this isn't a breast, would breast be part of the name?
Definitely.
Okay, so lymphocytic, mast,
And then a word that describes a disease process.
something, pathos, so diabetic mastopathy?
Yeah. Or lymphocytic mastopathy. Yeah, I guess they ran out of creative names because mastopathy is kind of where we're stuck with. But this is exactly what it looks like. So at low power, you have the sea of pink with that super glassy looking collagen. And then you have these lymphocytic cuffs around these really like squished looking separated lobules. So we don't have too much to look at there. And that's pretty much it. Oh, but one thing that you can notice, and actually it's pretty nice on this slide, is around the lobules, even though I know it's a little blurry just because of the resolution of this photo, but you can still appreciate that really thick pink eyeliner, that thickened basement membrane around, yeah. Do you see that? How around all the lobules, it's really prominent. Again, I know it's kind of blurry when you get up this high, but normally it's a little more wimpy. Like normally it's more like this, more like this. So this is actually thickened. Maybe someone who does maybe more medical renal might appreciate that more. But that's also another feature that you can see is the thickened basement membrane. That's associated with that.
Yeah, I think that is the best one.
Yeah,
So,
like I said, there's a couple, but really this isn't something that you see too often on biopsy, and you can imagine why, because of all this collagen, all this dense fibrotic stuff, like hyalinized out the wazoo, it's glassy. These lesions are so hard that if you're actually talking to the radiologist, they're gonna be like, man, that was like the most ridiculous biopsy I've ever tried to get in my life. I couldn't get the needle in. I had a really hard time getting any material out. So these lesions are very hard, like a rock. So you can imagine patients develop these things and they're really worried, and clinicians do breast exams and they're really worried because is this carcinoma?
So why is like the name like diabetic? Is it happen in diabetes?
It happens a lot in diabetics. Like most cases of this are going to happen in insulin-dependent diabetics, but you can also see this in patients, who have autoimmune thyroid disease, and some patients have none of that. So then you go into your differential of things, but most of them are going to have insulin-dependent diabetes. And long-standing too. Like it's not going to be someone who is diagnosed like 6 months ago with diabetes and they're trying to get under control. Like this is going to be someone who's been dealing with this for a long time. Okay, so that's kind of what we have here. So you look at that grossly, and the first thing your mind thinks is, is this benign or malignant? If you saw that on the gross, in the gross room.
In the gross room. Well, I would say malignant because it's not really well circumscribed. It kind of looks like it's pushing. It's white, it's hard.
Yeah, exactly.
Basically a gross description of most tumors, I guess.
Exactly. And they can be quite big, like 1 to greater than 6 centimeters. Sometimes they'll be well defined, but not always. They're going to have that same appearance that we saw on the previous slide, which was really nice. So like I say, like you have your sea of pink with your small blue islands. Excuse me. Okay, these lesions, positive for both your fibroblast and myofibroblast markers, so CD34, SMA, Desmond, CD10, those are all going to be positive. Because you're seeing so many lymphocytes, you're going to be worried about lymphoma. I guess we didn't go over that. So the lymphocytes are going to be predominantly B lymphocytes, with a smaller subset of T lymphocytes. So there's nothing really unusual there. And because of like the autoimmune associations, so you also have to think about things like inflammatory pseudotumor or IgG4 related disease. Lymphocyte globulitis. So basically what that's saying is when you have cancers in the breast, it can really cause a lot of irritation to the breast tissue around it. So you can get these lymphocytic proliferations associated with the lobules. So that's something a little different. But again, you wouldn't have like the same history. Like you wouldn't necessarily have the diabetic patient. You wouldn't have like this extreme like rock hard mass. Like they can develop masses and they would be firm, but they'd be able to get a biopsy and it wouldn't be necessarily as difficult. So treatment. So once you have a biopsy of this and you know that it's diabetic or lymphocytic mastopathy, you don't have to do anything after that. The patient can just go on whatever screening protocol they're supposed to do. If it really bothered them, you could take it out, but you don't have to do something. And again, because of the history of what the patients are predisposed with, so whether that's diabetes or autoimmune disease, or they're just unlucky enough to have these things, they can form new lesions. They're still going to have breast tissue. They're still going to be capable of forming those lymphocytic responses. So this isn't a one and done lesion. So you just have to keep that in mind and hope really that the patient doesn't develop more lesions, just because these can be so emotionally disturbing. Okay, so moving on, so vascular and our more neuro tumors rather than neuroendocrine, but neuro. Okay.
So assuming this is breast tissue again, see that, there's some skin. This big blue patchy area looks suspicious. Let's go take a look around. Kind of hard to tell, it's kind of just all runs together.
Yeah.
It does seem pretty bloody.
Definitely bloody. I guess we can start with benign or malignant.
Well, let's look at some of the features. It kind of looks a little infiltrating, maybe.
Yeah.
Doesn't really look well circumscribed. Coming in, looking at the cells themselves. I'm assuming these are the tumor. I'm in the right tumor, right?
This is still tumor.
Okay. Yeah. Let's do this. So some of these cells, I mean, they look kind of weird. They don't look very happy. They look kind of angry. So it's pushing it more towards the malignant side. There does seem to be these clefts. It's
Okay.
all over the place, and I think these are blood, maybe remnants of blood. There's maybe some degenerating blood cells here.
Mhm.
Let's just look around. It is kind of hard to tell because it looks pretty solid in certain areas, but there's like sort of blood
Yeah.
just flowing everywhere. So is this like a, well, I mean, the section topic kind of gave it away. It's a vascular lesion.
It's a vascular lesion. Yeah.
So, I say because this looks more malignant than benign, I would say angiosarcoma.
Okay. Is there anything you'd want to know in the patient's history that could help you tip one way or another? If the morphology's not helping?
History. What kind of history would we be looking for?
So, there's two things. We won't go into idiopathic because I feel like that's maybe a little unfair, even though that's the most common way you see these tumors. So let's say you have a 70-year-old woman, and 15 years ago, she had a lumpectomy for invasive ductal, and they did radiation to the whole breast.
Okay. So it could be secondary to radiation.
Yeah. You could have a woman who, sorry, I feel like I'm being sexist, but breast lesions are most common in women, who again had invasive lobular this time, and she had positive sentinel lymph nodes, so they went and did an axillary dissection on her, and she developed horrible edema of her arm that has been persistent for the last 15 years.
Okay.
You can also see that in those.
See?
And you could have all of the above or none of the above and be unlucky enough to have a MIC amplification. And get this. Or you could just be super, super unlucky and this is just a primary tumor.
Which, being from Cleveland, we have a pretty good chance of that.
Well, or at least getting a consult for it, or but okay, so the morphology actually does help you out with this. So at low power, like even though it's kind of darkly stained, you can still see that there are, if you back up a bit, back up, low power, breast is primarily low power, and then we go in for details. You have all these areas of blood. And I think it's easier to see at lower power, just because the stroma is so densely eosinophilic because of how they stained it. So the blood lakes and blood. I was promised rivers of blood.
Sorry, just had to set out links.
Yeah. Oh, no one else is a Box Trolls
It
fan?
won't go anywhere
Okay.
now.
It won't go anywhere. So you have all this extravasated blood because of all these poorly formed blood vessels, which I think when you highlighted over in this area, it's a little easier to tell maybe that they're blood vessels.
It's better well formed. The other one kind of just mashed together like a giant mass
Exactly.
of things.
Because, there are areas where we see some red blood cells in there. There's areas where it's pooching off into the lumen, because they like to do that. They like to tuft a little bit, which not so much in this lesion, because it's just getting so packed in there. It's trying so hard to proliferate. And, oh, look at those mitotic figures. Like, ugh, ugly, ugly. You'll appreciate this more when you have it on your own screen, but they are, scary, scary stuff. So yes, this is malignant as all heck. This patient probably had radiation, but who knows? And sometimes these lesions can be really hard to get around, especially like post-radiation. I guess something that's kind of interesting to consider is that idiopathic cases, excuse me, idiopathic cases tend to be deeper seated lesions, and they may involve the skin, whereas your treatment related will involve the skin. So if you think about that, if it starts percolating along the skin surface up in your superficial papillary dermis, it's just going to keep extending out, and they can be really hard to get around, because you also have to consider that even though ideally your surgeons want negative margins, they still have to be able to close these wounds, and that can present a real challenge if this patient has already had a mastectomy, they've had radiation, and they have this recurrence down the road when that skin's not as pliable and not as willing to help them do wound closure. So then they might have to think about, is this patient capable of having like extensive flaps? Do I have to think about skin grafting? There's all sorts of things to consider, and obviously none of that they want to consider if they're looking at still having positive margins. But yeah, so this is angiosarc.
Just this, where are these things in here? They're not staining very well. They look like smooth muscle?
Yep, those are muscle bundles.
Okay. Just a funny staining, that's all.
A little bit, yeah. Especially because everything else is so dark.
Okay.
Okay? Alright. So this first picture, so this is like radiation or treatment associated secondary angiosarc, where you have like those it almost looks like bruising across the skin. So you can imagine if that's what you're seeing at the surface, how far is it extending underneath? Really difficult to get around. And all that information we kind of went over already about the clinical. Obviously, these are extremely rare tumors, and they count for less than 2% of sarcomas angiosarcomas at all sites. Okay, and yes, so the infiltrative margin. So this is again similar to other lesions that we talked about, like the phloides and stuff. Is that often you can't tell where the lesion ends, because even if you have those areas of hemorrhage, what we saw on the slide was that the areas of hemorrhage were more off to the left, but we had tumor extending almost all the way to the right of that slide. So it can be very difficult, so you want to be extremely generous when you're submitting for these. The picture underneath is just showing a little area of tufting, so where you can get like these like pseudopapillary areas, and that's just because the cells are trying to proliferate so quickly that they're just piling on top of each other. Again, if you have solid areas like we have in the example that I gave you guys, you need to consider that these are high-grade tumors. Is this actually a carcinoma? So you'd want to do stains relative to that, and obviously like higher grade because we had more pleomorphism, more mitoses, and some of the mitoses were abnormal. You don't necessarily have to see necrosis, and the blood lakes. So we saw that massive RBC extravasation, and you'd want to make sure too that again we're not at a previous biopsy site, previous resection site, those kind of things. Positive stains. Okay, so this is a vascular tumor. So where we were looking before at PASH being negative for our vascular markers, this is going to be positive for every vascular marker you can throw at it. Your keratins can be focally weak in some cases, so don't rely on the keratins. If you're trying to differentiate with carcinoma, you'd want something more specific if available. And these can be EMA positive as well. Your myoepithelial marker, so your P63 is going to be negative. Molecular, so we talked about the MYC amplifications, that's chromosome 8, Q21, and that's actually seen in half of your secondary angiosarcs. In your FLT4, which is a VEGFR3 amplification or a tyrosine kinase receptor, that's on chromosome 5, Q35.3. And that's seen in a quarter of your secondary angiosarcs. So there's potential to use tyrosine kinase inhibitors on these lesions. It's not necessarily like the recommended treatment, but it is something to think about. Obviously, again, we want wide local excision, and you can do chemoradiation, but they don't really know if this helps or not.
Kind of started from chemoradiation, so.
Yeah. So things to consider, and also depending on their previous treatment, they might not be eligible for radiation and stuff. So those are things to consider too. It would depend on their dosing, what they actually radiated, all those kinds of fun things. So prognosis for this is generally bad. They tend to have distant metastases to a whole bunch of different areas, so also consider the contralateral breast. However, they don't tend to metastasize to the regional lymph nodes. So if you get a case like this and you're like, hey, why didn't the surgeon do lymph nodes in the area? The chances are is just because it doesn't pan out very well. So if they've done an ultrasound on the lymph nodes or a CT scan on the lymph nodes and they look fine, there's really no indication to take more. Okay. Last one.
Okay. Well, another very cellular bunch of cores here. Just zoom in and look around and see, but something tells me the fun stuff is in this area that I'm looking at right now. Okay, so at low power, it's kind of purplish on this stain. It's not quite blue, so that suggests there's something in there that's kind of counteracting the blue color.
Mm-hmm.
kind of like looks like pixie sticks maybe. The cells themselves are not that like pleomorphic.
Right.
They're pretty bland looking, but their cytoplasms, there's like a decent amount, and there seems to be very sort of a lot of white spaces sprinkled in, again like the pixie stick analogy. Would you call this like ground glass in any other sense? I don't know. I always
Like
get
I would
confused
call
by
this
the
more granular.
granular. Okay.
Yeah, because you can see like stop moving, like separate granules.
Yeah.
If you zoom in.
Yeah. It's
So
more,
this is granular, whereas like ground glass is like it kind of almost looks like sand on the beach, where you can't really tell like each distinct grain of sand from each other.
we should call that sand. It's ground glass because who grinds glass? But anyways, that's beside the point. So it's granular. So it's probably a tumor.
Okay.
So that's two of the words in the name. So last word is cell, right?
Right.
GCT, granular cell
GCT.
tumor. You can't really tell borders on this one, but over here it looks like kind of it's probably maybe encapsulated, not quite. But anyways,
Yeah.
that's more infiltrating. Never mind.
All right. GCT. Lots on GCT. Oh my goodness, there's so
Like that
much written
picture.
on this slide, right? Okay, well, what do you need to know? They're rare, okay? Like cancer itself is not that common, and when you're looking at, we need 1,000 cases of breast cancer specifically to have one case of this, and if out of all breast tumors, so that's also including things like our fibroadenoma that we see all the time. If we have 300 cases of carcinoma, this would be one of them. And out of all granular cell tumors that occur everywhere in the body, this accounts for 5 to 6% of those. Also known as granular cell myoblastoma, right? It kind of looks similar to that myofibroblastoma that we saw earlier, minus all the collagen. All right, so wide range of ages that are affected. You can rarely see these in men. About 10% of the cases will be in men. And these, again, are more common in African American women. So associated with a couple different syndromes, probably the one to really know is neurofibromatosis type 1, because that's one that they love to test. The other ones are a lot more rare, and those are ones that you guys can read up on a little bit. What's interesting about these is that, so carcinomas tend to be in the upper outer breast. So when you're looking at upper outer breast, you're thinking, okay, is this in the axillary tail? Is it pushing into the axilla? GCTs tend to actually occur at the upper inner breast, specifically near the supraclavicular nerve. Okay, and why? Because they're neural in origin. The masses are firm to hard, and they're yellow-white with well-circumscribed or spiculated borders. Okay, so what we saw in our biopsy of the lesion was both. One side looked more circumscribed, and the other side looked more spiculated. These can have skin retraction associated with them, and rarely or uncommonly you're going to see multiple lesions. So again, I'm describing something that's yellow-white, could be spiculated, it's hard, it's going to resemble invasive carcinoma on gross excision and when you're taking all your sections. Okay, so what did we see? We saw a solid, well-circumscribed, but not encapsulated tumor. Well, that's good because that's what we saw in our example. The tumors tend to be rounded, they can be spindle-shaped. Our example was rounded with small bland nuclei. That describes what we saw. No real prominent nucleoli, and this abundant cytoplasm with eosinophilic granules. Okay, in our example, there may be a little more amphiphilic, but the point is that these granules are going to be PAS positive, diastase resistant. Now, on occasion, the cytoplasm can be clear. So with that, then your differential will become things that have clear cell change, including metastatic clear cell renal cell carcinoma. Most of these lesions are going to be benign. However, there has been some criteria proposed that can help you determine if this lesion could be malignant. And it's basically all the things that we normally think about with malignancy. Okay, maybe vesicular nuclei with prominent nucleoli, well, that one's maybe a little iffy because what if they're reactive? But pleomorphism, we shouldn't really see. Necrosis, we don't like seeing. Increased mitotic activity. So all these things considered together can help you figure out if it's atypical versus malignant. However, keep in mind that even if it looks malignant on histology, it doesn't predict whether or not it's going to have a malignant outcome. Other things to note is if all you had was some little focal pleomorphism and you didn't fit any of these other criteria, you call it benign, you walk away happy, okay? If you have just, again, these rare sprinkled mitoses throughout the lesion, that doesn't count either. Okay, so positive stains. So neural in origin, S100 positive, calretinin is going to be positive, inhibin A, NSE, beta-catenin, CD68. Wait, what about all our breast stains that we love to throw out, right? So your hormone receptors are going to be negative. Keratins are going to be negative because this is neural, this is not carcinoma. SMA, which is actin, so I have that in there twice. Anyway, SMA, SMHC, and Desmond are all going to be negative because it's not muscle, right? So our so really when we were saying like it's also known as granular cell myoblastoma, that really seems like a misnomer now, right? Because all your muscle stains are negative. Molecular, basically no molecular, okay? There's some really rare stuff where they're talking about, well, there was a CDKN2A gene deletion. Don't hinge on that. Just for right now, there's no molecular, okay? They're going to take these out by surgical excision, and almost all these are benign. Look at that. About 99% of these lesions are going to be benign, with rare reports of recurrence and very rare reports of malignant GCT. So when we have malignant GCT, we're going to have metastases to either lymph nodes or the lung, and that's going to help you more than looking specifically at the histologic features. Those are important and should be described in a note, but you shouldn't necessarily expect that the patient's going to have a poor outcome simply because they have more features consistent with malignancy or atypia. Okay, that's what we have for this week. There are 11 cases in the challenge cases. Some of them are entities that we did not go over in this lecture. So be sure to check those out. And next week we should be back with an unknown session that is completely about malignancy. So we're going to kind of cover a little bit of everything, but we'll go over the basics that everyone likes. And that's it. If you like this video, hit like, subscribe. If you have comments, suggestions, things you want to see, let me know in the comments. And thanks for your time.